Friends, I'm back again, and I'm showing you a case of mitral stenosis, and I just want to share with you how would you actually make an assessment in mitral stenosis. What are the common mitral stenosis is pretty common in our part of the world, so we see it very frequently. Yes, please subscribe the channel so that you are notified as and when I would launch another video. Before I begin with the case, I'm going to show you the normal anatomy of the mitral valve. Mitral valve doesn't mean only the leaflets. It's a mitral valve complex. That's what we call. It includes the annulus because all those things, abnormalities happening do involve the annulus. This is called mitral valve apparatus. Then you have a large anterior mitral leaflet. Remember, the anterior mitral leaflet is mighty and large. Why it's important in rheumatic heart disease, I would show you, because this is going to produce a posterior mitral valve movement anteriorly. So this is the posterior mitral leaflet, which has a larger circumference, but it's smaller in size, and then it's associated with the stage 1 to 3 types of cardi with the two papillary muscles, and that's how the mitral valve looks like. The PML is smaller, the larger, mightier anterior mitral leaflet. And what are the causes of mitral stenosis? The most common in our part of the world is rheumatic, because it's still prevalent. Then we, in the elderly population, we have a degenerative mitral valve, which happens because of the mitral annular calcification and the calcification extending into the mitral valve and into the cardi. Then we have a congenital mitral stenosis of various types, parachute mitral valve, arcade mitral valve, which I have discussed in another video on my YouTube channel. You can search that. And then there are uncommon causes which produce a mild mitral stenosis, not severe usually. Those are other collagen disorders, infiltrative disorders, and even carcinoid rarely is likely to produce that. In the pathology of the mitral stenosis, because of the rheumatic etiology, which is quite common in third world countries, still you have an infection and inflammation over the mitral valve leaflets, also involving the cardi. These are because of the antibodies against anti-streptolysin ASO antibodies. And then you have, this is the hallmark of mitral stenosis. There is a commissural fusion, right? Apart from the commissural fusion, later on you get a calcification of the mitral valve as well, and that's what the pathology of the mitral valve stenosis. It gives you a fish mouth like an appearance, produces a thickening of the cardi right through and up to the papillary muscle, involving thickening, curling, and shortening of the mitral valve, and enlarged left atrium because of either mitral stenosis or mitral regurgitation, or the combination of these two, leading to a dilated, smooth-walled left atrium. Doming is very, very important of part of the mitral stenosis. It shows you a significance of the mitral stenosis, because doming happens because of the pressure gradient. The valve domes when it opens rather than the leaflet separating it out. This doming happens in almost all mitral stenosis, and this indicates what? If you have a doming, it indicates pliable valve. If there is a degenerative mitral stenosis, there is a calcification of the mitral valve, this doming would not occur. So this is a doming of the mitral valve as it opens. This doming does not happen in one or two peculiar situations. One is that it does not usually happen in intravalvular membrane of mitral stenosis. I showed you one case in one of my videos on a congenital mitral stenosis. Then you have an intramitral ring or a membrane which holds the mid part of the ventricle. The leaflets are open, so doming does not happen. Same, the doming does not happen once you have a calcification of the annular ring extending into the mitral valve. Mitral valve leaflets are not pliable, so they don't dome. Another important hallmark of the rheumatic mitral stenosis is a posterior mitral leaflet moving anteriorly. This is the normal excursion of an M mode, and this is the posterior mitral leaflet movement. You see the posterior mitral leaflet movement, which is going posteriorly, anterior going anterior, posterior going posterior, right? And then in mitral stenosis of rheumatic etiology, because there is a commissural effusion, the PML is pulled up along with the anterior mitral leaflet, so it produces anterior movement of the posterior mitral leaflet, or a PML, which is indicative of commissural effusion, a hallmark of rheumatic stenosis. Now, once you are trying to assess the severity of the mitral stenosis, following things should be noted, and level 1 indication that it should be done in every patient. You should do a pressure gradient. You should do the mitral valve area either by planimetry or by pressure half time, or ideally both. You may or may not use a continuity equation, a PISA method, to look for degree of mitral stenosis, and in case you have in doubt, there is a class 2 indication that you can use a stress echocardiography to bring out the gradient. I would show you the case there. Then you might have to recommend this patient a balloon mitral valvoplasty. In this case, you need to show the pliability of the valve. Is it suitable for a balloon mitral valvoplasty? You need Wilkins score and or other scores for that. Then you have to see the hemodynamic effects of mitral stenosis, the LA enlargement, the pulmonary venous pressure increase, pulmonary arterial hypertension, and you have to see the complications of the mitral stenosis like atrial fibrillation. You have to also notice any evidence of a thrombi infective endocarditis in these patients. This is an old classification of the mitral stenosis, but still holds true. We are believers of this classification, where the severe mitral stenosis is the mitral valve area is less than 1 centimeter square. The recent guidelines recommend a lower threshold for this, but we still believe in this classification. Mild is more than 1.5, moderate is between 1 to 1.5, and severe is less than 1 centimeter square mitral valve area. Then how do you judge the severity of the mitral valve based on the mitral valve area? What are the methods to calculate mitral valve area? There are 4 methods: planimetry method, then the method of pressure half time, the method of a continuity equation, and uncommonly used PISA method. Planimetry is when you see the short axis view of the mitral valve. So if you take a short axis parasternal view at the level of the mitral valve, and then you can do a planimetry of the mitral valve orifice, okay, and this orifice is planimetry. You calculate the mitral valve area, you can see the mitral valve in motion, and the planimetry. Obviously there are certain limitations there. For example, if you have a lot of calcification of the mitral valve not only becomes irregular, the calcification puts shadows, which so that the other part of the mitral valve is not very clearly seen. You might have an open commissures after balloon mitral valvoplasty. Then you can see the mitral valve commissures are open. It becomes difficult to actually trace those commissures to make an accurate assessment of a mitral valve area by planimetry. Now, it is quite possible that this may not be the narrowest portion causing the stenosis. The stenosis might be happening at the chordae level, right? It might not be happening predominantly at the valve level, at the cardi level, so then the assessment of the mitral severity would be wrong. The most common thing why the planimetry fails is that you may not be in the right plane. You may not be cutting the mitral valve in the right place at the tip. You might be cutting the mitral valve little proximal towards the atrial size. You would get a little larger size of the mitral valve unless you are on the tip of the mitral valve, because mitral valve with domes, it forms like a cone. So you have to be on the tip of the cone rather than anywhere inside. So if you are anywhere inside, the diameter and the circumference or area is going to be more. So this is the most common abnormality or a problem what we have. How do you do a planimetry view? You just go to a long axis view, PLX view, and from there you go to short axis view by rotating the probe by 90-degree clockwise, and then you see the cross-sectional area at the mitral valve. I find it little easy. First focus on the aortic valve. You see the tri-leaflet aortic valve, and the mitral valve tips are going to fall in the same plane. Just angle it inferiorly, caudally, and when you come caudally, then you will see the mitral valve tip or opening of the mitral valve. Then you need to optimize the gain setting so that all the borders or edges of the valve are seen very clearly. You need to make at least 2 or 3 measurements in the normal sinus rhythm and about 5 measurements in the atrial fibrillation to make an accurate assessment on averaging of the mitral valve area, because most of the decisions are going to depend upon mitral valve area, so you need to be very careful in calculating it. So tips, again, many a times you not been able to go to the tip of the mitral valve, then it may be having a rough assessment. You see the tip separation, and once you see the tip separation, if it is less than 8 millimeter, then usually it is a severe mitral stenosis. Then you can use if you have a 3D equipment, then you can use an X-plane or a biplane mode, where in the one plane you see the mitral valve and you put the line or the cursor here, the 90-degree you would see the mitral valve like this. You put the cursor here, okay, because it's a biplane, you see it. And then if you have a 3D equipment, then you can actually look at the mitral valve. The mitral valve here is looking on this side, then you need to rotate this volume to get this in the middle so that you see the mitral valve properly. So similarly in this patient, this is an atrial side view, this is the ventricle side view. Look at the mitral valve opening just on one side, opening on one side. So it's opening on the one side. You may not be able to get the view properly unless you make it in the middle, and then you can actually planimeter this very nicely. Pressure half time. So it's a decay of the pressure. Normally you have a left ventricle end diastolic pressure here. The pressure continues to rise with the diastole, and this is the atrial pressure. Now the atrial pressure, with the atrial pressure, it falls gradually as it's emptying into the left ventricle. Now this time taken for the pressure to go to the half the pressure level is called a pressure half time, which is a very important way of calculating mitral valve area. It has a linear and an inverse relation with the mitral valve area. You have a more severe mitral stenosis, the PHT would be higher. And the formula used is you have 220 divided by pressure half time is called Hatley's formula, and then you get a mitral valve area. For example, pressure half time is 220, then the mitral valve area would be 1. And if it is more than 220, it indicates severe mitral stenosis. So if mitral valve pressure half time is 220 or more, it indicates severe mitral stenosis. How do you take pressure half time? You put the usually the continuous wave Doppler here, or a pulse Doppler if the velocities are not very high. Once you do a continuous wave Doppler, you get this kind of tracing, and you trace this line. This gives you pressure half time. Pressure half time here is 188, less than 220. The mitral valve area is more than 1. It was 1.2. So CW is always preferred. You should make an angle correction if it is required. Then mark the peak point, mark anywhere in the slope of the mitral valve. Once you slope the E slope of the valve, this is EF slope, you mark this slope and follow the slope, and then your system would give you a pressure half time. In patient with atrial fibrillation, you need to have 5 cycles to make an assessment, but it's not very easy. What are the caveats here? You must optimize the gain. If you have increased gain of the CW Doppler, look at the kind of beard or the kind of waviness right on the top because of the increased gain. What you guys are going to see, should take a measurement, is the median velocity, the brightest velocity line what you see in the trace. It's not the peak velocity, it is the median velocity which you should take. So if you reduce the gain, you see this median velocity very nicely. So you take this median velocity. Okay, beware that many a time the AR signal kind of looks the same, but the velocities are very high, and this is the AR signal. Be very cautious. It should not give you confusion. You should not take a AR signal and consider it as a mitral signal. Now there are still more caveats, because pressure half time does not depend only on the LA pressure. It also depends upon the LV pressure. So if the LV pressures are higher by some reason or not, then the pressure half time is going to be abnormal. Pressure half time would be lengthened and mitral valve area would be overestimated when you have a large LA because of the mitral regurgitation. LA is so compliant that the pressure increase in LA is not there. And in a volume overload situation, but more common than that, we have a pressure half time which is shortened. Why it can be shortened? When the LV pressure is higher. Look at the LV pressure. If the LV pressure and diastolic pressure is higher, the pressure half time would be shorter. And this happens, the common condition is associated aortic regurgitation, or you have a diastolic dysfunction of the ventricle. So if you have this situation, the pressure half time would be shortened and the mitral valve area would be underestimated, right? Now, how do you, many a time you don't get a good line for the pressure half time. The slope is not as you would have wished to have. Something like this, then where do you take? Now, one thing is that you don't take it at the peak. You have to take at the median velocity. You see the median velocity, it's something like this. It's not a straight line. Where do I take? Should I take here? Should I take here? That's what I'm going to discuss. So this is how the median, this is where you should take, and the median is not straight line. So where do you take? Now it's called a ski phenomena. Once you have the pressure increase, now this is the slope, this is called a ski. The first portion is dependent upon the LA compliance, should be ignored. You should take a distal part of the slope to take. For example, so if you are taking a measurement like this, you're going to be inaccurate. You are taking a measurement like this, you are inaccurate. This is the right method of calculating. Distal part of the slope is ideal for calculating pressure half time. So this is again thing I am showing you. This is the wrong method of calculating pressure half time, the right method of pressure half time because of this ski phenomena. So in this patient, the correct pressure half time would have been this. So what are the pitfalls in pressure half time? Many a times it's difficult to take a measurement because the AR jet merges with the mitral stenosis jet and you can't differentiate between the two. Ski effect also complicates the slope visualization, and I told you there are many other hemodynamic factors which can affect, like aortic regurgitation, like the diastolic dysfunction. LA compliance can change the pressure half time. And remember, pressure half time should not be applied to prosthetic mitral valve and degenerative mitral valve. They are going to be inaccurate there. So this is the study which showed the pressure half time calculation based on a continuity method compliance by pressure half time, the so variable. So it's recommended in the prosthetic valve and a calcified valve. Please, you do not use pressure half time to calculate mitral valve area. So next, or probably the last, is the pressure gradient. CW is preferred, and then you take the highest velocity, you calculate peak and mean velocities, and in atrial fibrillation, this is how you calculate or trace the mitral valve, and then you get a peak and a mean velocity. These are also important. Pressure gradient, but when you're doing a pressure gradient, do mention at what heart rate are you doing it, because increased heart rate can increase pressure gradients. So the pitfalls, it depends upon the heart rate, it depends upon number of factors, mitral regurgitation, then anemia, hyperdynamic states. So a lot of conditions can change the pressure gradient across the mitral valve. It's not a very accurate method. By continuity method, I discussed it in one other talk. Then you have to calculate the flow of the across the valve, the aortic valve. You have the aortic diameter. You have a VTI. Once you have a VTI of the aortic valve, you can calculate the stroke volume. You can calculate the blood amount of blood flowing through the mitral valve, and you get the VTI. And from here you can calculate the mitral valve area, provided there is no aortic regurgitation and mitral regurgitation. PISA is very uncommonly used because the PISA is usually not spherical in the mitral stenosis. PISA generally is reserved for regurgitation lesions, particularly aortic regurgitation and mitral regurgitation. So once you've done with the gradient, you've done with the mitral valve area, now you look at the mitral valve anatomy for a feasibility of balloon mitral valvoplasty. You see the thickening of the valve, the commissural fusion, then you see the valve thickness, extension of the calcification, subvalvular apparatus, and these are the scoring methods. Wilkin is the most common. Now grade 1 of the mobility. Mobility is number 1, valve mobility. Highly mobile and doming mitral valve, or could be restricted in the middle, or there is no movement, no doming. So it is called score +4. +1 is just tethered at the tip, and otherwise both PML and AML are doming and mobile. This indicates that the score given is +1. Then subvalvular apparatus. How far the subvalvular apparatus is affected from mitral valve. If it is just minimal thickening of the chordae close to the mitral valve, it's given score +1. In case the extensive papillary muscle also is involved and extensive involvement of chordae, it's given +4. Then you have a thickening of the valve. If the valve is minimally thickened, the thickening is 4 to 5 millimeter. Remember to put off. You go to the basic screening, you put off the harmonics when you're taking the thickness measurement, and consider the considerable thickening. In case it's more than double the thickening of the valve, then you can say it is +4. Calcification is just a small speck of calcification or heavily calcified. You give scoring 1, 2, and 3 and 4, and we know if the score is more than, then this score is helpful. +8, 4 indicates the valve is not suitable for the balloon mitral valvoplasty. Less than 4 less than 8 Wilkins score is ideal, but there are other problems with Wilkins score, so we use various other scoring methods, in particular eccentricity of the opening of the valve due to the calcification. This eccentricity itself and the doming, level of doming, is also an important component of making an assessment for balloon mitral valvoplasty. So another important is the calcification. It's important to note whether the calcification is just at the tips or it is involving the entire commissure. So if the commissure calcification is there, commissures are stiff, and if you do the balloon mitral valvoplasty, commissures cannot open because there is calcium there. The tear would happen anywhere else in the mitral valve. So if there is a combined scoring you do, you should use Staria's scoring system for calcification if Wilkins score is less than 8 and there is some calcification, and this Noon score should be used in case Wilkins score is more than 8. You still trying to attempt to open the mitral valve by balloon mitral valvoplasty. This is one patient which we did an exercise stress testing. This was a doctor whose complaint of dyspnea. We calculated mitral valve area at the resting was 1.3, and the gradient also was just mean gradient of 8 millimeter of mercury with a heart rate of 67. So we made him do an exercise. He could only do exercise up to 7 minutes on the Bruce protocol, and after exercise you look at the gradient gone up to more than 40 and 29. The gradient of more than 30 here indicates a severe mitral stenosis, and this doctor went with the balloon mitral valvoplasty and his symptoms of dyspnea on exertion abated. So thank you very much. Do subscribe the channel if you want to be notified if I post any other new video on echocardiography. Bye till then, and keep learning.